Dr. Dharmanand. He requires actually no introduction. He started his career with MBBS at Madras Medical College, then obtained an MD and DM in rheumatology from Madras Medical College. He has got more than 15 years of experience in rheumatology, and currently he is a consultant rheumatologist at Manipal Hospital and also one of the directors of Chandray. And what I know is he has given hundreds of speeches. He is fond of speaking and we are fond of listening to him. Dr. Dharmananda, please.
Good afternoon. Thank you, Chairperson, for the kind introduction. I love talking. I hope I finish in time. Rheumatologists wear many hats at many times. Many a times we are physicians trying to figure out what is happening to the patients. Sometimes we become immunologists trying to use immunosuppressives and try to, because of this factor, rheumatology until the methotrexate era was always grouped with rehabilitation. Most of the older departments in UK and US have a tag, Department of Rheumatology and Rehabilitation. So rehabilitation department and rheumatology department will be there in one of the remotest corner of most of the UK hospitals. The methotrexate has changed the profile of a rheumatologist, and that also the advances in immunology also made it mandatory for a physician to be a rheumatologist rather than a rehabilitation specialist or an orthopedic surgeon. So let me define what is rehabilitation, how it is different from a usual medical process. WHO in 1980 has defined it as a process by which people with injury or disease are able to regain their former abilities or achieve their optimal potential, if not full potential, optimal potential. So this sentence gives us the crux what a rehabilitation specialist would do. It can be defined also as a management of disease consequences, in contrast to physicians or rheumatologists who bother about the causation of the disease and the disease process and pathophysiology. So in crux, a rehabilitation specialist manages the disease consequences after it has had its toll. The goal of a rehabilitation specialist would be to reduce symptoms, which is true for all the doctors and specialists involved in the field of medicine. The entire medicine and rheumatology has come out of treating pain, and they always strive to improve function and minimize disability. What is important is when we have a patient with some difficulty and disability, the approach cannot be like a protocol. When you are treating a diabetes or even rheumatoid arthritis, lupus, we can try to follow a protocol, but when you come to follow a rehabilitation method, it needs to be patient-centered. We have to sit with the patient, decide what he wants, then give them the best way to go about it, depending upon their constraint and their ability to visit the hospitals and financially afford the expensive rehabilitation proceedings. So we need to assess the degree of disability. Once that is done, periodically after the rehabilitation process is on, we have to keep on reassessing how they are doing. As I have told you already, we have to identify the problem which is relevant to the patient. We have to ask what is their most important difficulty. A housewife might say that I have difficulty washing clothes, I have difficulty cutting vegetables. So we have to try to address that factor rather than try to improve certain things which may not be relevant for that particular patient. A player, there are few rheumatoid arthritis patients who want to have a shoulder problem but they want to play golf. So that rehabilitation strategy in that male patient would be different from a housewife who wants to cut vegetables in a better way. And we have to relate their problems, try to convert it into meaningful aspect for that patient and cater them and use the rehabilitation techniques to which is suitable for their environment. Rehabilitation has to be given by by a team. A single member cannot really do everything because nobody is really trained in doing all the aspects of the things which I am mentioning. The patient and the family, of course, they are the most important members. It is extremely difficult to make a transition from a normal person to a patient. Being a patient, unless some of you have become a patient, would never realize how difficult it is. They have to make a huge amount of adjustment to their lifestyle. They have to listen to so many people whom they don't know, and they have to believe them what they tell. So it is a huge, they form the cornerstone of any team, medical treatment program, rehabilitation program, etc. Rheumatologist probably in rheumatic diseases related rehabilitation, because of his familiarity with these diseases and also familiarity with the rehabilitation process, he can be a kind of team leader. But the main person would be a physiotherapist and a rehabilitation consultant. Physiatrists are not very commonly available in our country. So physiotherapists and rehabilitation consultants are the guys who do the job on the ground. And wherever they are available, occupational therapists are good resource persons. Orthotists, podiatrists are a rare breed in India. I have not seen a single qualified podiatrist in our country. We don't have a training program at all. And as I have insisted in my first sentence here, it is difficult to make a transition from a person to patient, and clinical psychologists do help in patients kind of understanding their illness, and give them a good coping strategy to cope up with the illness, which they have to do day in and day out for a long-term basis. And the nurse specialists are very useful in understanding the patient's problem from their perspectives. So we can train some of our nurses to do this job. Dietitian, of course, somebody who is obese, nutritionally. Rheumatoids are sarcopenic, they are cachectic. So they need a good diet advice. And last of our osteoarthritis patients are obese. They also require dietary counseling. And last but not least, we should never forget orthopedic surgeons. They are the salvages. Sometimes when everything we cannot do, so they can do the repair work and patch up work and make the patient get back to their feet and give them little more productive quality of life. I'll give you a brief example of one of our patients whom we saw recently. She's a 30-year-old lady with 5 years of rheumatoid arthritis. When we saw her a couple of years ago, 2-3 years ago, she was totally bedridden. She could not even walk, and she has not walked for 2 full years. She came in an ambulance with both her knee bent totally at more than 100 degrees, and she had a flexion deformity in her shoulder, elbows, and knees and hips. Then 2 years later, she now can travel with the help of her husband to her native place, which she has done after 5 years. She is able to cook. Her son told me that after 2 years, mom had made him the dishes which he liked, like kesari bath and of course. And she has a good self-esteem. She is able to do most of the activities expected from a mother. She is able to play her role as a wife, mother, daughter-in-law to a reasonable extent. She still requires some help when she is coming out. She requires a walking stick, but at home she is independent. She had a good self-esteem. So how did we do it? What did we do? What did I do as a rheumatologist? We identify the patient's problem. She had quite an active disease. I had to give her a disease modifying drug. I had to inject her knees with corticosteroids so that the knees become pain free. So, and I guided them to the appropriate team. So this is what I did. I didn't do any physiotherapy myself. I didn't try to mobilize myself, but we did educate the patient the need for long-term rehabilitation in her case, because she has not walked for 2 years. To make her walk, it may take another 1 year at least. And I have to appreciate the family and the patient. Initially, they were very skeptical. 90% of the patients whom we see in this state, in spite of telling us, they give up. They've already given up. They never try. We try, we can do this, it may take 1 year to take up, they give up and they never come back. Most of the patients, I have made a home visit, which I've not done it for last 10 years, 7 years. They were all crippled patients. Rehabilitation is possible, but none of them came forward. So we have to appreciate this patient and the family who has supported it. And our physiatrist did a wonderful job, gave her a good stretches, wedge corrections, and made her knee straight. It took almost a year for the bent knee to become straight, but it did become straight, and she could walk a little bit with her damaged knees. And physios did a wonderful job in re-educating her muscles. And OTs and orthotics gave her a splints which she can wear at night, and they also give her appropriate walking aids. And of course, last but not the least, the orthopedic surgeon, after a year after this effort, did 2 replacements for her knee joint, and that has resulted in a patient who is able to be independent again. So with this took almost 2 years for her to be in this level. So this is the enormity of the task in a patient who has gone to that stage. The entire effort of the rheumatologist now is to prevent patients from going into this stage. So what are the rehabilitation techniques regularly used? Joint mobilization is done by the physiotherapist, strengthening exercises, stretching exercises, and we need to protect the joints which are already partially affected. The joints which are already damaged by the immune inflammation needs to be protected. So they have to avoid squatting in the floor. So a lot of education goes into this, and physiotherapists do use a lot of physical modalities in various forms, and we have to give them an alternate strategy. See, when somebody says, I can't wash my clothes, they have always washed their clothes sitting in their bathroom and washing with a soap and a brush. And simple thing like they cannot really think of an alternate way of washing their clothes. So we have to really use our own innovativeness and give them some tips on how to go about washing the same clothes in an alternate way. Probably with this current situation, our clothes are never that dirty except our kids, and we can use Nirma or surf powder, keep them soaked for half an hour, and then only brush the areas where it requires brushing. They don't need to squat at all. They can use a plastic chair and sit in their bathroom. Simple advice can make a lot of difference to their life. And of course, braces and splints, aids and devices, and sometimes wherever facilities available, modification of the environment also makes a difference. This is what most of the physiotherapists do. They are the most important resource persons when it comes to rehabilitation. They do the donkey's job. They do the exercises. They do the stretches. They advise them the endurance exercises. They use all the HIIT modalities. And remember that the strategies with a physiotherapist should use vary depending upon the stage of the disease. Rheumatoid arthritis of 6 months duration would require a totally different strategy compared to a rheumatoid arthritis of 20 years duration. And education, patient education is again a cornerstone. It may take few months for the patient to accept that they have a chronic disease. Sometimes when we try to tell everything during the first visit or second visit, talk about disease modifying drug, talk about steroids, this, they get scared and run away. I have found out that they go for shopping. They see me first, then go to Chandrasekhar, then go to Anupama, and unless they convince that everybody is telling the same thing, then they start taking treatment. So it takes some time. So spend some time educating. If they are really scared, give them some time. Don't push your disease modifying drugs, steroids on the first visit. If they are skeptical, give them some educational material, give them some good websites, ask them to get back to you so that they come back after asking few doctors. They may come back and say, okay, doc, I am ready to take it now. That is a stage where they are more receptive to your treatment. So this is an important aspect of managing the patient on a day-to-day basis. Changing to this type of toilet makes a huge difference to patients with osteoarthritis. It's very simple. Costs only 3,000 to 4,000 rupees to change your toilet like this. You know, I'm in a rented house, I can't do it. Spend 3,000. Otherwise, you end up spending 1.5 lakhs for a knee replacement after a few years. And using these kinds of things are now getting available. Patients with deformities can use lot of different types of spoons and cutleries to facilitate their day-to-day living. It is now available online in India as well. And other countries, people use this kind of aids to move around, but it's probably our roads, platforms, shops are not user friendly till now. And orthotic supports and splints are very, very important to prevent damage, prevent pain, give rest and improve the mobility. This can make a knee little better. This will prevent foot drop and the hind foot valgus deformities. This can be very useful in patients with carpal tunnel syndrome and wrist arthritis. Thumb spicas are extremely useful in those who have D quire 1 stenosynovitis. In countries where facilities are available, the team of orthotists, occupational therapists visit the workplace, try to modify the workstation, use them a much better sitting chairs facilities, which is not feasible at this moment, but we can try to give little bit of tips to our patients so that they can modify within our resources. The problem is only few centers in India train people in physical medicine rehabilitation. We need more centers to do that so that they also become part of the rehabilitation team. And rheumatology rehab training is virtually non-existent. Even in the places where their PMR facilities available, there is no rheumatology department at all. And even in physiotherapy and occupational therapy training programs, the exposure to arthritis is very, very minimal. So the manpower becomes a major issue. And you have to remember, the physiotherapist also have to remember that rehabilitating a patient with rheumatic diseases like ankylosing spondylitis, rheumatoid arthritis, osteoarthritis is extremely different from rehabilitating an younger post-trauma or sports injury person. You can very easily rehabilitate a Virendra Sehwag or Anil Kumble. But to rehabilitate a lady who is struggling to walk, a frail rheumatoid sarcopenic lady, to get them back to normalcy or near normalcy or functional independence is totally different task. Most of our patients, I went to this hospital, they asked me to do 20 days physiotherapy, and physiotherapy caused me a lot of pain because the physiotherapists by training, they are trained to treat an injury or a normal person. So the methods they used were terribly painful for these patients. So they didn't follow the rehabilitation advice. So as physicians, we need to familiarize with simple exercise techniques, which is not difficult. You go to YouTube, every exercise possible is demonstrated by somebody. So we can always see how it is done and we can always suggest to our patients. We also need to enthuse our physios, OTs and orthotists to take interest in assessing rheumatic diseases. There are simple tips like your ankylosing spondylitis fellow cannot really move his neck, and sometimes drinking coffee becomes difficult. So they may have to use a bendy straw to make things easier. Unless suggested, they cannot sometimes innovate. And using a towel or a rubber sheet to open the jars can make a difference. Simple lifting techniques, lift anything close to the body will prevent injury to the back. So back pain rehabilitation requires some amount of change in the rehabilitation techniques. And we have to teach few simple techniques which we all can become familiar. So we are struggling in our institution, both at Manipal and Chandray, to really build a rehabilitation team. We have now a good team to take care of the joint restoration clinics, but it's a big struggle to train them and retain them. And now we have the technology, and we can utilize the innovativeness of many people who are working in different fields. There are people who work in metallurgy, and I'm sure Indian Institute of Science is full of guys who have a lot of ideas. So some of us can sit with them to create some innovative rehabilitation tools. Overall, the rehabilitation resource in rheumatology is scarce, and we need a lot of effort to build up a team which can give good rehabilitation care to most of our patients. Thank you very much for patient hearing.
Thank you, Dr. Dharmanand, for highlighting rehabilitation, which sometimes takes a backseat in the management. We can take the questions at the end of the session.
Good. There are no questions. We don't have a full-fledged orthotic department, but we have people who are trained in orthotists. They visit us once a week and try to help our patients on
they visit our physiotherapy department.
You don't give the footwear or corrective which hold the correction.
Yes, you said next it, yes.
You do it in a center.
Yes, we don't do it. We don't have a manufacturing facilities. They come, take measurements, do it in their center and supply to the patient.
Because a lot of patients ask us where to go for that.
Yeah, only center is available where they have facility to do chappals is Hosmet and St. Martha's, where they have the workshops. And we have a kind of a space crunch to have it in our center. But we use the resources of a person who is trained in orthotics.
Where you find it good? That's what I personally. Where you find it good? This orthotic department, Martha's.
For simple things, they are okay. Martha and Hosmet, both of them can make a simple chappals with the arch supports. They can give minimum splints they can do.
Regarding squatting, Indians for ages we are used to sitting on the floor for puja, for taking food, and Indian system of toilet we are used to it for generations. Even elderly people, irrespective of age, they are used to it. 70 years, 80 years elderly people with osteoarthritis, sometimes normal joints also. So do you, as a routine, do you advise all these people to switch over to dining table system and using Western toilets? Because for ages we are used to it, sitting on the floor in Indian toilets. It is practically impossible to ask them to switch over to the Western system of using dining table and Western toilets. Even for normal people, healthy people, asymptomatic people, elderly, do you advise them as a routine to switch over to things? Because it is something not acceptable. And Indian toilets, it's not easy to convert the Indian toilets into Western toilets, as you rightly said, because of rented houses, affordability, there are so many factors involved. What is your advice?
I agree fully with your comments. It's an extremely difficult task to change the habits. Old habits die very slowly and very difficult to change. If a person can squat and get up without any discomfort, they can continue to do that. There is no problem. Not every old person develop osteoarthritis. Many people escape from it, they can comfortably do it. But if they have pain while squatting and getting up, a significant pain and difficulty, if they require support, that means their knees are not able to take the load. Every time you squat and get up, 6 to 8 times our body weight goes into the knee. When the osteoarthritic process has already started in, the cartilage would get more damaged. So we need to educate them. It's difficult and it's partly in our mindset also. If you try hard, surprisingly, many people do adapt. Some people refuse. I have always done my puja. I have to tell that our gods are very, very adjustable. But we are not adjustable. Some kind of punch word sometimes strikes them somewhere. And they can, after that, duck, okay, duck, okay, duck. Then because they think that how to do puja without squatting. It is always possible. You can sit in a chair and do puja. God doesn't refuse your pujas. Our gods are very flexible. Even the Islamic God, church, Jesus, everybody accepts people praying in another different postures. So there is no religious reason is required. So we need to really tell them. Most people do listen, and after a certain time they can't. How many of your osteoarthritis patient have to go use the Indian toilet? They defecate standing. They can't squat. It's very awkward. And it's only, even converting your old Indian toilet would cost not more than 3 to 4,000 rupees. If your tenant, your landlord doesn't want it, you can remove it and change it and go. Still it is cost effective. There are a lot of makeshift like hospital stools are available, and I think there are few, if you search around, there are few kind of dispensable units which can be even taken to the fields actually nowadays where the sports meets and happen. Now they have a temporary toilets which can be done.
Excuse me, my niece is suffering from Churg-Strauss syndrome. Does it come under rheumatology?
Yes, it is a type of vasculitis. Chandrasekhar is going to talk next about the Churg-Strauss syndrome. I think it can be done.
Excuse me, my niece is suffering from Churg-Strauss syndrome. Does it come under rheumatology?
Yes, it is a type of vasculitis. Chandrasekhar is going to talk next about the Churg-Strauss syndrome. I think he will highlight.
Okay, thank you.
Thank you, Dr. Dharmanand.